and that insomnia might be onset insomnia. This means they can't get to sleep, difficulty going to sleep. Maintenance, that they wake up in the night, they have a middle insomnia, or terminal, which is they wake up very early in the morning and then cannot get back to sleep. Insomnia is often a presenting complaint for depression. Many times our patients don't say, I'm depressed, or I'm here because I need help for depression. Many times we find that their presenting complaint is, I can't sleep, or I'm having trouble sleeping. And so that's important to be aware of. There are many factors affecting sleep, like stimulants, nicotine, various food reactions, especially yeasts and milk, prescription drugs, nighttime urination, fear, anxiety, discomfort, pain, many things that can affect sleep. But also looking at what's happening in the brain at this time and how it connects to the nutritional status of the person. Serotonin is a key neurotransmitter related to depression. It's one of the chemicals that our brain makes that's very important for our mood. 95% of serotonin is actually made in the GI. Don't ask me how that all happens, but it just connects to our nutrition. So when we're dealing with depression, we're dealing with sleep, many times it might have something directly to do with our nutritional status. Just look at what happens here, that 5-HTP is a precursor to serotonin, which then is needed for melatonin. Melatonin is decreased in the elderly and in those with depression. B12 is decreased in the elderly, but B12 is required for release of melatonin. And vitamin D converts serotonin to melatonin. So you can see there's various processes there that are essential for serotonin. GABA, which is GABA aminobutyric acid, increases our relaxation and calmness responses, and magnesium converts glutamate to GABA. So again, there's many processes that are going on in our body that are really important. Okay, just a few things regarding sleep possibilities for those with depression to live well. Remember, our brain does not sleep. It never sleeps. It's always working. And so sounds, temperature, comfort of the pillow, the bed, darkness, lightness, all affect our sleep. So important to monitor the environmental stimulation. Also, restricting caffeine, offering a nighttime snap might be helpful. Perhaps there's some bedtime rituals that are meaningful, that might be religious or whatever, but just to help the person relax. And there's various other things we can use also, such as herbal teas, aromatherapy sometimes helps patients. Sleep music, you can find CDs that really help and soothe the person into sleep. And we also can use medications if we need to. One that's been recommended from a practitioner is Xyrem. But I also encourage you to go to the Sleep Foundation website. They have a lot of very helpful information on sleep hygiene. Okay, and we also can use various supplements for sleep. There's botanical medications such as valerian, which is our herb, helps relax, passion flower, hops, and skullcap, herbal teas such as chamomile or sleepy thyme. These are things that you can access fairly easily. Vitamin B complex is a good idea to take that at night. It really can help people sleep, as well as some of their mineral supplements, magnesium, iron, and calcium. Very good to take that, a combination at nighttime. And there's also some homeopathics that can help with that too. Okay, moving on, another manifestation, of course, of depression is concerning activity, either too much or too little. Oftentimes people are dragging around, don't want to get out of bed, or if it's an agitated depression, they're always on the move. So looking at their activity is important to help them manage and live well. And a key thing here I just want to emphasize is that our research on exercise is really pointing out that exercise alone has a tremendous impact on improving our mood and our ability to handle stress. And some people are using Feldenkrais, Tai Chi, and yoga, which all have to do with movement and balance, and these are finding to be quite helpful. So whatever facility you're in, keep moving. Keep your patients moving. That's a very important way to maintain wellness for depressed patients as well as all patients, if at all possible. I remember when I was in China a few years ago, I walked through the public parks, and there were hundreds and hundreds of people out there doing Tai Chi. It was really great to see that. Every morning, early in the morning, they'd be out doing their Tai Chi. But there's a lot of research coming out that shows yoga, Tai Chi, Feldenkrais are very important in terms of managing depression. So it is possible to live well with depression. The sadness, the hopelessness, the no motivation, trouble concentration, the sleeping problems, all of these can be managed in many ways. The worst thing is not to manage them at all, not to treat them at all. Because once diagnosed, 80% of those who are clinically depressed, including older persons, can be effectively treated by various therapies. And most often, it's a combination of the things that I've mentioned, not just one. But there are other possibilities too, and just want to point out a couple of those, like cognitive therapy, which deals with the negative self-ruminating thoughts that many times depressed people have. Light therapy, can use 10,000 lux lights, that can be effective. Electroconvulsive therapy has shown very effective, and sometimes when people cannot take medications because of side effects, electroconvulsive therapy can be another option. We also have some brain stimulation therapies called transcranial magnetic stimulation and vagal nerve stimulation. These are really medical interventions that can affect the mood. In addition, there are some medications, which today we're calling serotonergics and noradrenergics, and maybe you're thinking of the old name, antidepressants. That's kind of what they are. These are used in the elderly. We have to use them with caution because some of them cause sedation, which causes, of course, sudden blood pressure falls and safety issues, decreased absorption, metabolism, excretion, so we have to look at the dose of these in our older people. It also takes more time to attain effectiveness. The SSRIs, which is a certain category of these medications, can produce dependency. We have trouble sometimes with medication adherence to the regime for elderly people. They don't believe to take medications, they don't want to pay for them, whatever. And so many things go into being cautious about them. Nevertheless, they can be very helpful, again, for those that have a more severe depression. It needs to be decided on, certainly on an individual basis. But nursing considerations with these are important. And one thing to remember, kind of an overall thumb, is that you should start low and go slow with dosing. And the dosing for elderly people certainly has to be different than the standards for middle-aged and younger people. So, what are the possibilities then for living well with depression in these elderly people? Well, if we focus on meaning and purpose, hope, resilience, nutrition, safety, rest and sleep and activity, I think that we can make a difference in helping people live well and diminish some of the effects of depression. Just a few things about trends. There's really a lot of trends going out there with our growing demographics here. We're really becoming concerned, hopefully, about how we're going to care for this population in the future and what is going to work for them. There's a lot that's coming out on neurocognitive brain wellness, brain rehabilitation. And folks, this is so basic. It says go to bed at the same time, get up at the same time, eat a balanced balanced meals, take in enough fluid, exercise regularly, avoid neurotoxins like alcohol and nicotine, and experience some joy and fun in your life. Now, if you and I didn't learn that way a long time ago, it's very interesting that these are still the key things that are coming out. When we deal with people who have chronic illnesses, they have vulnerable brains, it's very important to have regimes and schedules for just daily activities. We also are finding out a lot about what's called neurotrophins, which are really proteins. They're key regulators of neurogenerative processes in the brain. This is pretty exciting to see that maybe there's some of these cells in the brain that can regenerate themselves. We're also looking at centers of excellence for depression treatment. 20 years ago, we started these for cancer, centers of excellence for cancer, and it has really moved us into a knowledge base about cancer that we did not have before. So we're looking at those being tied to, research in large areas that could study and do research and move forward with depression care. And then we're also, if you go into the literature, you can find a lot about depression care management models, and we've heard about some elderly care models already. These are just a few, and I offer you the website here to look at them. But they're all systematic team approaches to treating depression, and they're looking at especially depression in the elderly and those who have not been responding to other treatment interventions for depression. So we can look at living well with depression in the elderly. We can also look at living unwell. And if we're living well, we have to have some kind of treatment that will increase quality of life, the lifespan, as well as wellness. If we don't treat it, if we're in the untreated, we're going to be living unwell, and we're going to have certainly diminished quality of life, mortality, increased mortality, disability, healthcare costs, of course, substance use and abuse, family disruption, and a lot of suffering. So I just challenge you, which side here do you want to be on in terms of living well with depression in the elderly? So it is possible, in closing, I hope you've seen that we can imagine ways that can help us, help our elderly live well with depression. If we look at the meaning, purpose, hopefulness, resilience, nutrition, safety, sleep, and activity. Those are key things, and there's more too that I encourage you to imagine. But I encourage you to reflect on these possibilities as well as others. And as we face this global epidemic of depression and the fastest growing global epidemic in terms of the elderly persons, I invite you to join in the efforts of imagining how we can further assist our elderly in living well with depression. Thank you very much. I don't know if we have time. I have to find for a question or two, or are we up for a time, Natalie? Okay, all right. Okay, but I'll be available if anyone has any questions that you'd like to pose to me afterwards. Yeah. Yes. I think your question is about bearing witness to suffering. Is that what you said? Oh. I think bearing witness would have something to do with the whole consolation model experience, right? As I understand it anyway. It's a good point. You can answer the question. Is there another question or comment? Anything more? I think we're ready to move on. Thank you, Natalie. Yeah.
So what I want to make sure and tell you guys, or remind you guys all, is that we do have the reception that's getting ready to get started in the reception hall in the back. Those of you that have attended from the distant sites, we really thank you for coming today, and we look forward to hearing from you and seeing you tomorrow. Well, we will be thinking of you tomorrow. I know we can't visually see you.